So without further ado, I am extremely excited and honored to introduce you to our speaker to kick off our new Advanced Practice Provider series. Dr. Deb Mayer joins us to highlight the role of advanced practice providers in cancer survivorship care. So Dr. Mayer is an advanced practice oncology nurse who has over 40 years of cancer nursing experience, education, research, and management experience. Dr. Mayer served as past president of the Oncology Nursing Society, was a member of the National Cancer Institute National Cancer Advisory Board, holding a presidential appointment, and the Board of Scientific Advisors. Dr. Mayer was elected as a fellow of the American Academy of Nursing. She is active in ONS and the American Society of Clinical Oncology, and has served as past chair of the ASCO Survivorship Committee. At UNC, she is the coordinator for oncology focus of the Adult and Gerontology Nurse Practitioner Program. Her program of research focuses on the issues facing cancer survivors and improving cancer care. As a nurse who works frontline with cancer survivors, and as a cancer survivor herself, she brings a unique perspective to her clinical, research, and health policy collaborations with cancer survivors, primary care providers, cancer specialists, and researchers. I am proud to have Deb Mayer as a colleague, a teacher, a mentor, and a friend. Deb, outside of your bio, what is something you'd like to share with the audience about yourself?
The fact that I'm retiring at the end of June. So that's why this talk is so important to me, so that you guys can continue the work.
Well, it's a little bittersweet. We're excited for you and all you've done, and thank you for sharing one last lecture before you go. So we will have poll everywhere. This is an example of what it will look like on your screen. So as you think about survivorship describes the experience of moving beyond cancer diagnosis and treatment toward wellness. I will read this disclosure and we'll get back to the poll everywhere question. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. William Wood and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Dr. Deborah Mayer has no financial relationships with commercial interests as defined by the ACCME. So back to our poll everywhere question. Survivorship describes the experience of moving beyond cancer diagnosis and treatment toward wellness. So it looks like everybody is answering true. So thank you. And Dr. Mayer, I turn it over to you.
Thank you. And I'm so glad there's such a good turnout today from so many different institutions in the area, because I really do, I'm going to give you the bottom line now, just in case you get distracted, is I think advanced practice providers are the group to own survivorship care and are best situated to deliver it, because we look at the whole person in a way that when people are, and I'm going to mostly make my comments to people who have no evidence of disease, ending therapy. There are all kinds of survivors, and I'll talk a little bit about that, but that's what most of my comments today are about, because we can help them integrate what's happened to them and develop a new life after cancer. So can I have the next slide? So you can continue on. Thanks. So let's just find out from the audience whether you currently do follow-up visits for cancer patients, and it looks like we'll give people a minute, but so far it looks like 100%, but that will change over time.
Looks like the majority of our audience does.
And the ones that don't, there's still an important role for you in helping to establish what sort of the roadmap looks like and the game plan for patients from time of diagnosis throughout, whether you're doing follow-up visits or not. So I hope you'll find some things that will apply as relevant to your practice as well. Can I have the next slide? So what I hope to do is, just anchor all this in current and future trends about survivorship. I want to define it because although that first question is sort of right, it's not actually the whole definition. I'm going to talk a little bit about long-term and late effects, but I'm going to talk a lot about the unmet needs of survivors. We do a much better job of taking care of the physical needs during treatment and taking care of the cancer than we do in necessarily helping people integrate what they go through. I'm going to talk about your role in delivering this care, and I'm going to give you some resources that you may or may not be familiar with. So the artwork that I'm showing is from Lilly Oncology on Canvas, and it's done by survivors, it's done by caregivers, and it's done by clinicians. And so I think a picture is worth 1,000 words with all of these. But if you ever want to be moved, go online and look at these images because they are really breathtaking in many different ways. And although this says, basically I'm more than a statistic, I am going to talk about cancer trends. So this slide you may be familiar with, but I started in oncology in 1975 when we really didn't have a lot of survivors, and over half of our patients died of their cancer. And so in those days, there was no hospice, there was no palliative care, there was no survivorship. And we did take care of the whole person for the rest of their life because it oftentimes wasn't that long. But that has changed, especially over the last 20 plus years. And this shows you the age and number of survivors as they grow. The blue line at the bottom is basically those under 50. And although we do see some earlier cancers in those who are younger, cancer is pretty much a disease of aging. And you can see the green, purple, and teal colors are the aging groups of those over 65. And those numbers are going to continue to increase. So right now we have about 17 million people in the U.S., which is about 5% of the U.S. population, and about 2/3 of them are over 65. So whether you got Gero content in your APP program, you are going to be taking care of older patients. And so you need to be familiar with normal aging, you need to be familiar with polypharmacy, you need to be familiar with a lot of the comorbid conditions that are very common for them to have, because that's what they're bringing to the table with us. Next slide. But not all survivors are alike. And so the highest volume of survivors are breast and prostate cancer, which is probably, we're all familiar with that. And the next group way beyond that is colorectal cancers. But the other is that there's other cancers that the survivors have higher need. Think about somebody with head and neck cancer and all the issues that they're faced with if they've been treated with surgery, chemotherapy, and radiation as far as nutrition, their dental issues, their swallowing issues, their thyroid functioning, and what have you. So we need to remember that not all one size fits all. We need to be thinking about the populations we're dealing with as well as where they are in the cancer continuum as well. Next slide. This also tells you that we think about survivorship as sort of immediate after treatment's over, but in fact, we have many people who have survived a long period of time. When you think about 45% of our survivors of that 17 million, 19 million people is greater than 10 years out. And think about whether you're seeing them in your practice or where they're being seen by their primary care provider. But most survivors, 2/3 of survivors, are going to be surviving at least 5 years. Now, we know that's not true for some cancers, but for many, that's true. Next slide. So we have to really be thinking about the long-term and late effects. And this is a image from North Carolina, the left is the incidence rates and the right is the mortality rates. And you can see this is where the equity issues in healthcare are become really apparent, where there are some counties where the mortality rates are way higher than the incidence rates are on the left-hand side, but the whole state has close to 500,000 survivors. So you think, oh, 60,000 new cases a year doesn't sound too bad for North Carolina, but when you think about that cumulatively, you know, you're talking about larger numbers and who's seeing them and where are they being seen. Next slide. So now I'm going to talk about defining survivorship, because when I recently did a stint for 2 years at the National Cancer Institute as the interim director of the Office of Cancer Survivorship. And there have been a lot of people who were saying this definition of survivorship didn't fit well with a lot of groups of people. And so we went through about a 1.5 year exercise of, you know, polling advocates and clinicians and researchers to talk about the definition of survivorship and what's wrong with it, and we updated it. So we can have the next slide. So the thing that hasn't changed is cancer survivor in the 80s was named anybody who's been diagnosed with cancer for the balance of their life. And the reason that matters is, you know, how they're treated, the thoughts about what their needs are start at time of diagnosis and treatment. And they're considered a survivor for the rest of their life. But what we updated the definition is to really call out that there's many types of survivors, those who live with cancer and those who are free of cancer. And it's not meant to label any one person. And so, you know, somebody may want to be called a patient or a victor or a veteran or any number of things, or not want to label themselves in any way. This is meant to think about the population as a group of people who have unique needs, not necessarily to label any individual. Next slide. So the kinds of people that fit in this category are those who may be cancer-free. And I think there's very few people, only about 10% who've been diagnosed with cancer that get away scot-free. But they may do fine for the rest of their life, but that is a small percentage of people who have been diagnosed. There are those who may have treatment complications, and I frequently use the 2 patients that I had as examples who have peripheral neuropathies, and they were considered mild by us, but in fact were life-altering for these 2 people. One was a dental hygienist, and she could not feel the tools she had in people's mouths, and you wouldn't want somebody with sharp instruments in your mouth. She ended up having to change her careers. And the same was true of a surgeon who couldn't tie sutures anymore. So things we may look at because we see a lot of it, may think of these things as minor, but for the person experiencing them, they may be life-altering. There's also those people who may die from a late recurrence. And certainly melanoma and breast cancer are 2 cancers that are notorious for late recurrences, but that can happen. Or we know that 20% of new cancers are diagnosed in people who have a previous history of cancer, which means that your history taking of previous illnesses is really important, especially getting details about a previous cancer of their diagnosis and treatment. We also know that those living with cancer, ovarian and lymphomas are 2 examples of those cancers that wax and wane over time, where people may go into remission but then recur, which makes the roller coaster of that very difficult. And those who may have advanced cancers that never quite go into remission, but are kept stable or under control with the treatments that we have. So again, we're talking about all kinds of survivors. Most of my comments today are going to be talking about those with no evidence of disease who are ending initial treatment. Next slide. The other part about survivorship is that in general, the definition means that it's somebody who's lived through a life-altering event. That doesn't mean that they're all cancer. Somebody could have lived through, you know, Katrina or Sandy, or have lived through a violence in one kind or another, or what have you. So there's all kinds of life-altering events, but it's often found to be a dynamic process. How somebody feels during diagnosis or the year after may be very different than 5 or 10 years later. It has a degree of uncertainty about it, and it's often a life-changing event. It may be subtle or it may be more dramatic, but it does alter one's life. And oftentimes there's some positive as well as negative things, and we can say that about COVID. You know, you could say that there's Some positive things that came out about COVID, if you think about spending 365 days, 24/7 with your family members, or that could have been a negative experience, depends on your family. But it does change. And that the other part is, given people's experience, it does not, it means that it also has to be applied to who they are. Like in one study we looked at parents with metastatic disease who had young children. It was shocking to me how many of them had lost a parent when they were young from cancer. And so if you didn't know that, their feelings about hospice or leaving their children were very different than the people who hadn't had that experience. Next slide. So let's ask another question.
So our next poll everywhere question, how long does your group usually follow patients when treatment has ended? Less than 5 years, 5 years, 10 years, or the remainder of their life?
And this is only about your practice, not there's no right or wrong answer for something like this. It helps me understand. Okay, so many of them are remainder of their life. And so that's going to be a real issue for you as time goes on, because as you saw from that growing number of people, there's going to be more survivors needing follow-up care that may challenge you to see new patients who need a diagnosis and treatment initiated. And so part of what I'm going to be talking about is how you do this follow-up so that there's a transition back to their primary care provider over time. And that's going to require a culture change as well as template changes and thinking through all of this. Next slide. And we're going to talk a little bit about long-term and late effects. And this artwork's called The Road Home. And if you saw the words in it, it's fear and hope and other things like that. But very few people are unscathed. And I want to say that Julia Rowland has a comment that says, just because you're cancer-free doesn't mean you're free of cancer. And that's about the long-term and late effects, because you may have no evidence of disease, but it's the gift that keeps on giving. Next slide. So there is a number of long-term and late effects, and it doesn't mean that everybody's going to get all of them. And there's a number of factors that may contribute to them, just like we saw with COVID, that if you had comorbid conditions and obesity, you may have been more at risk for a more severe case of COVID, or maybe at a higher rate of dying than somebody who didn't have those. But we also know that lifestyle behaviors also play into it, as well as the treatment exposures, as well as environmental and genetic factors. Next slide. So we need to think when we're looking at somebody, not just that they had cancer and were treated for it, but we need to know what type of cancer and what type of treatment. So if somebody had a sarcoma in the leg, we don't have to be worried about radiation to the breast and the risk for additional breast cancers. But if somebody had childhood Hodgkin's and they had chest radiation, we need to be thinking about breast cancer in younger women. So you need to understand the type of treatment. And it's really interesting because I have MP students who go into primary care practices, and oftentimes at best they may say history of breast cancer and give no details about that. And that's one of the reasons survivorship care plans are going to be very important. And also about comorbid conditions. So think about it when somebody has diabetes and we give them antiemetics like steroids to keep their nausea and vomiting under control. What does it do to their blood sugar or their hypertension with some of the newer agents? Next slide. But there are a number of studies that have looked at survivors over long term, and the fewer comorbidities somebody has, the better their quality of life. But look at this. On average, cancer survivors have 5 comorbidities, and 23% in this one study had over 7 comorbidities. And so their quality of life was really dependent upon the type of cancer and their treatment, but also the number of comorbidities. But in general, cancer survivors have a lower quality of life than the general population that's controlled for age and all those other things without cancer. Next slide. This was a meta-analysis of 64 studies looking at quality of life in longer-term study survivors. And as you can see from the description, they were at least 5 years out, but the range was from 2 to 26. They were older. They had a variety of types of cancers, and their quality of life scores were not very good. The large negative effects were related to their physical health, their role functioning, and their mental health. And it wasn't dependent upon the type of cancer, their age, or the time since diagnosis. So these are big hits people take. Next slide. Another study, this was a Canadian study of over 10,000 adult survivors. They had on average 6 concerns, but they only talked about 2 of them and sought help for 2 of them during a visit. So that's a big concern, is that, you know, when people come in to visit you and you're pressured for a short visit, that they're not telling you everything because they forget, or they, you know, the moment they walk in the door. So you should know that most of the time that they will have physical concerns, emotional concerns, and may even have practical concerns. Those who had a primary care provider did better than those without. And so one of your jobs as an APP from time of diagnosis on is to make sure that your patients have a primary care provider who manages those 5 comorbid conditions, because we don't do that. Patients may think we look out for them, but we really don't. And so we need to make sure they have a primary care provider that will follow them along with us, because we're really focused on the cancer and its impact. And so we need to make sure that we have a partner, which means that they're in our electronic records and they're getting copies of our notes, and they get the copy of the survivorship care plan if they get one. Next slide. Their more specific physical concerns were things that aren't going to be a surprise to you, which is fatigue is one of the biggest ones, change in cognitive function, you know, CRS, can't remember shit, or chemo brain, which is not really chemo brain, change in sexual activity, other kinds of issues that you can see here, and a lot of it depends on the type of cancer. Anxiety and depression, which I'll talk about more, are very common. And then practical concerns. So, you know, HIPAA and the Affordable Care Act may prevent discrimination for health insurance, but it doesn't protect against discrimination against other kinds of insurance. And when I went to get life insurance, I was limited on what I could get because of my history of cancer. And the same thing is returning to work or school. There was just a paper published yesterday that showed, you know, we do so much for kids with cancer about not falling behind in school and keeping their teacher in the loop and their classmates. We do squat for people who are working. And yet we find that during the first year of diagnosis and treatment, many of them have to cut back their hours, may take an early retirement, or are unable to keep doing their jobs. And yet we don't ask them about that or do much counseling around that. And there's a great website called Cancer and Careers that people who are working should be informed about, that may help them with those. Also taking care of their family, paying bills and transportation. We know from, I mean, just getting out of our parking lot and paying for parking is often an issue. Next slide. So this was another meta study, you know, looking at all those. This is just showing you that the physical domain of feeling tired and not being able to do the things you used to do are really distressing to patients, and they're not really getting a lot of coaching or counseling about how to manage that. I want to talk about fear of recurrence is also another big emotional concern, and I'll give you more specifics about that. But even if somebody's 5 or 10 years out, they may still have a lot of unanswered questions, or we may think that they understand because they do onco-speak. You know, they can talk about what their ANC is or whatever, but not really fully understand what's going on or having their questions addressed. And with seeing women at end of breast cancer treatment, that's often when they asked about the risks for their family or whether they should get genetic testing even if they didn't up front. And so don't assume because they've been here for 5 years that they're good to go. And you'll see this repeatedly, that those who are younger, and in all these studies, younger means less than 65, where my definition of middle age is 15 years beyond whatever you are at the time. Those who are anxious, have poor quality of life, or have a lot of comorbidities or ongoing symptoms have a lot more unmet needs. Next slide. Now, this is a good review that when we think about the physical, psychosocial, and supportive care needs of people, if you look at the prevalence range, about a quarter to a third of people have ongoing issues over time. So that means about 2/3 or 3/4 of people eventually do okay and figure this out. The question is, how do we differentiate them, and how do we check in to make sure that the people who are in that 1/3 to 1/4 group are actually getting the help that they need and not offering it to people who don't need it, because we don't have enough people or resources to go around for everybody. So this is one way to start screening and thinking about who needs to get referred to mental health counselors or who needs to get referred to rehab or other kinds of things. We can't refer every patient all the time, so this may be helpful for screening. Next slide. So the other is the more symptoms somebody has, the more perceived stress they're under. And this was a similar study that looked at the mean number of symptoms were 9 in over 600 adult survivors, which means if you have 9 symptoms, you're going to be pretty stressed out. And it's a catch-22 about that. And I just looked at, we've just done a survey at UNC of about 100 people on and off treatment. And it's very interesting to see where the unmet needs were. And a lot of them were around their unmanaged symptoms, but also about trying to figure out how to get their life back together or how to manage their life with dealing with cancer and the afterlife of the treatment and side effects of that. And, you know, we're very focused on the cancer and we're very focused on delivering all these things, but they need help with how to integrate all of this, because their life after cancer is not going to look like their life before cancer. Next slide. And this is about anxiety and depression. And again, most people do okay over time, but there's a subgroup that have severe depression and severe anxiety. And we need to be picking up on them and getting the help they need. And again, here's a tip off if somebody's having a lot of financial problems, have a poor quality of life, or complaining about cognitive issues, they may be experiencing more anxiety, depression than somebody else, which makes a lot of sense. Next slide. I want to talk about fear of recurrence because we really don't talk a lot about that. I would think it's pretty normal for somebody to worry about their cancer coming back. The question is how much it interferes with their life. If it's the week before they're coming in for their annual checkup or their repeat mammogram or scans of any sort, of course they're going to be worried about it and thinking about what's going to happen, because you don't go in to get a test and not think about what if the results are not normal. I talk to patients a lot about it's when it interferes with your life. If you're worrying about that the week after you got your last mammogram and then the next 51 weeks you're worrying about it, or you're so worried, like I had a patient who couldn't drive by UNC without getting really upset whenever she saw the UNC blue. That did it for her. Even if it was for a football game, it just brought all this stuff up. That's when somebody needs help in managing that, and they should be referred. But there are evidence-based interventions, including mindfulness-based, stress-based interventions, cognitive behavioral therapy, are all been shown to be effective in the distress associated with fear of recurrence. And again, it doesn't mean that it changes over time. It may be a little bit better over time, but again, in a small but significant group of survivors, in over 1,000 survivors, 17% of them had significant fear of recurrence. And I don't think we talk about that enough and see whether that interferes with their adherence to their surveillance or their long-term adjuvant therapy. Next slide. And here's, again, I think this is a repeat. Sorry, I should have taken this slide out. Next slide. Okay, let's ask about care plans.
So how many of you have ever created and delivered a survivorship care plan in your practice?
Great. Well, this is very heartening to me, because even though survivorship research hasn't really been strong in showing they make a difference in outcomes, from a patient education point of view, we know that comprehension and retention of information is increased with multiple modes of administration. And I won't ask you now, but I can tell you, I usually ask audience, how much do you think people retain when you talk to them during a visit? And the average for cancer survivors or people with cancer is about 10%. So let me just ask you this. If you knew that your visit with your patient, they're going to remember 10% of what you do with in that closed room, why would you not give them something in writing to reinforce that visit? because we know that that's going to increase retention. The other part is we know about teach back is also an evidence-based strategy to see what patients really understand. The survivorship care plan is one of those tools where we can validate their understanding of their diagnosis or their treatment and clarify things that may need to be fixed in the medical record. That may be an error, but also then review the surveillance plan, what a recurrence may look like and when to call in and come back to be seen, as well as talking about health promotion and other things. So I'm glad that 2/3 of you have been involved in that. And I think we need to do a lot more to make this a standard of care, but it's not enough to create the piece of paper and hand it off. It really needs to be used as a tool to discuss these things with individuals. Next slide.
So a follow-up question, do you talk to your patients about health behaviors after treatment? For example, smoking, alcohol use, and even physical activity? I like the 100%.
And people may or may not have time to do that or think about that, but patients, part of survivorship care is talking about health behaviors because the health behaviors that cause cancer can cause a recurrence, like if somebody continues to smoke. And we know that even with lung cancer, if somebody quits smoking after they've been diagnosed, their rate of recurrences are lower than if they don't. We know that alcohol is a co-carcinogen. So if you have cervical cancer and you're smoking and drinking, you may have not only cervical cancer, you may get other cancers. And that physical activity is the magic bullet for things like fatigue and mood. And so talking about health behaviors is an important and integral part of survivorship care. Next slide. Now, this is a little busy, but this just came out last week. Although it says 2019, this is new data that looked at 2011 and 2016 and change in what happens during a survivorship visit. The first columns are about follow-up care and talking about how often people will be seen and when they're coming back. The second columns are late or long-term effects, the emotional and social needs, lifestyle or health recommendations, and summary of cancer treatments. So the purple at the bottom is discussed in detail. And this is not different in the last 5 years when this was done. And I can tell you multiple studies have the same findings, which is we do pretty good, but not excellent about follow-up care when people are going to come back to see us, how often they're going to be seen. We talk a little bit more about things like long-term or late effects. Emotional and social needs always is the lowest in any of these studies because we do not really take the time to explicitly address some of these things. And lifestyle or health recommendations is a little better than that, but not as good as follow-up. We do better with surveillance than we do with anything else. But again, that's because we're focused on the tumor and not about all these other health issues that somebody may be facing with, and we need to broaden our perspective. Next slide. So I've been sprinkling that in throughout all of these, but let's talk a little bit more specifically about the role of the APP. Next slide. So most of what we do is focused on the newly diagnosed and planning their treatments and the last year of life with end of life with palliative care and hospice and being treated for metastatic cancer. But in fact, the biggest component of cancer care is the follow-up visits. And it's not only the biggest volume by number of visits, it's the most costly part of cancer treatment. And so we really need to be paying more attention to how we do that because it really takes up a lot of our healthcare system dollars and personnel as far as seeing people. And this, again, has been reaffirmed in many studies. Next slide. So we really need to think about how we deliver survivorship care, and the Institute of Medicine's report basically outlined its prevention and surveillance for recurrences and new cancers, which is really what we're pretty good at. Mitigating long-term and late effects physically and psychosocially, we're not as good with that as we should be. Health promotion, we're less good about, but really is important because whatever we promote for cancer care is going to improve diabetes prevention or management and heart disease. And if the cancer survivor doesn't die of their cancer, they are going to die of heart disease. And so these are pro-inflammatory issues that the health promotion I just mentioned will be very good for preventing or managing heart disease as well as cancer care. And the economic effects, which has really become a much bigger issue since this report came out, and people making decisions about what they can afford to do for cancer care. And then care coordination, because think about all the people who are involved in taking care of somebody with 5 comorbid conditions. If we don't have all of them in our records and they're not getting our notes and we're not getting theirs, we're asking the patient to be the care coordinator, and we put that burden on them, and they end up being their own navigator, which is really very burdensome. Next slide. There was a recent national study that looked at what survivors want. And I want to go over this with you because we talk about patient-centered care, but we really don't do it very much and don't do it very well. They felt that the 2 overarching principles for survivorship care include underscoring the chronic nature of survivorship to prepare people. It's not treat them and street them like when I was early on in cancer care. We really need to say that even if you are potentially cured, not that we'd like to use that word very much, but if you're no evidence of disease and you're off treatment, this still becomes a chronic condition where they need long-term follow-up and maybe having long-term delayed effects. Many people are really surprised by that as time goes on. They thought they would be one and done. The other is they feel how haphazard our healthcare system is, and they feel the negative effects of being in a system that's not a system. And so they really are asking us to create a more integrated, holistic system to better manage their ongoing issues. And if the minimum thing you do after today's lecture is making sure every one of your patients has their primary care provider listed or you help them get one, that will go a long way to do that. Next slide. What they want is to help understanding the expectations of survivorship care and help learning how to live with their cancer. And we spend so much time on surveillance and recurrences, we forget that they're really struggling to learn how to live with less energy or other kinds of issues that they may be facing. Finding peer networks for emotional and social support. And if you don't have your own programs within your systems, you should be aware of Immerman's Angels, IMMERMAN, Angels. They are a national group that will match your patient with somebody else. And the mentors, they call them mentors, will then work with that individual who they've been a survivor who's been trained on how to work with other survivors. So there's always a way to find other people that they can talk to. And then helping them find the resources and information they may need. It doesn't mean that you have to deliver all these things. It may be you have to be aware of what's available in your community, like Live Strong at the Y or Silver Sneakers or other kinds of resources that may be out there. And not to ignore their mental health needs, because a lot of times there's a real shortage of mental health providers, but needing help with managing the anxiety, depression, fear of recurrence, and even a smaller subset who actually develop PTSD. Next slide. What they want us to also be able to do is respond to them and their needs and helping them become more empowered and engaged over time. I think it's very hard to be an empowered patient when you're newly diagnosed, but it is something that people can take on more. And that's where self-management comes in as well. In the UK, they actually give patients self-management protocols about when to call, but how to manage a lot of these side effects, how to manage what they're doing. And then making sure that we have meaningful communication that is two-way between the survivor and the provider. Next slide. And lastly, we need to be working within our organizations on how to improve coordination of care and transitions across providers. It's people really need a roadmap of how to do this. And offering practical life support about how to get their life. Because what happens, and you know this well, when somebody's done with their treatment, their family and friends go back to work and say, okay, you're all done, this is good. But it's the second year that I tell patients is often when they're absorbing what they've been through that first year. And that it hits them emotionally that they've been through all of this. And oftentimes it's the second year that they find harder to manage than the first year. and creating sort of infrastructure or processes to help facilitate continuous care, whether it's handoffs to the primary care provider or shifting to full APP follow-ups. Because again, I think when we see patients in follow-up visits, it allows the oncologist, whether it's surgical, radiation oncology, or medical oncology, to see the newly diagnosed patients and get help that way. But I think that we can spend more time and focus on the kinds of things that they're saying they want, and to reduce barriers to access to the care that they need. Next slide. So this is what they said that they want. They want to know who to contact if they have questions or concerns, if they develop signs or symptoms that they think may be a recurrence. I often use that as an opportunity to say to people, if they have something they're worried about, mark it on the calendar and mark 2 weeks from now. And if they still have the problem 2 weeks after, that maybe is a time to call or follow up about that. Most of us have colds or the flu, or we ache or we hurt, we do whatever, but within 2 weeks, most normal benign kinds of things are going to go away. But that helps them let go of it and then come back, and if it's still there, to pay attention. Obviously, if they have a progressive problems with pain or headaches or things like that, that's a little different. But also what to expect in follow-up care and what their GP should be doing, as well as the oncology team, and then to give information in writing. Next slide. What actually happens is, in these studies, they felt like they had a good care in detecting recurrence. They wanted extensive testing to get reassurance, and we need to educate them that doing a lot of testing doesn't give them that reassurance. We're not going to do head-to-toe PET scans because we're going to expose people with a lot of radiation from CAT scans. They want psychosocial support. They want consistency and continuity of care. And they do want longer term follow-up, but if we educate people from the early time that eventually they'll be transferred back to their primary care provider, they'll be more prepared for that, and then help them not on one visit to say you're not coming back anymore, but prepare them for those changes. Next slide. And this is what patients said they got across 3 different health systems that were really good about surveillance, not quite so good, but a little better on late and long-term effects. And here you go, not so well about emotional and social needs or giving written summaries. And that didn't matter where they were seen or what type of cancer they had. Next slide. This is what they want. They want diet and lifestyle information. They want information about exercise or physical activity. They want to know about work issues, if they have pain, and how to manage all these things. And again, this is more of a patient-centered, comprehensive approach. Next slide. And this is a nice study that said if they have to be transferred back to primary care, this is what they want. They want to know about that early on. They want to have a primary care provider they know and trust. They want a timeline and a roadmap for when this might happen. And they want to be able to know that they can always come back. And so when I would see patients, I would say, I'm going to see you for the next 3-5 years. But after that, your primary care provider is going to take over, but you'll always be able to come back if you develop a problem. Next year, it's like, we're going to see you for 2 or 3 years, and continue to remind them. And their primary care providers are very open to what they need to do. And as a transition, and knowing that we will always take them back if they develop a recurrence or new problem, has made those transitions a little bit easier. Next slide. Part of that then is helping people figure out how they can manage some of these things. And we don't spend a lot of time in educating patients about how to do that. And I think we need to do more research in that, and do more work with patients about what they do when they're home. We see people in a snapshot, they live the video. And if you've ever been sick or needed help, you know that implementing this at home is often a real challenge and need help in doing those kinds of things. But that's going to be an important component of survivorship care. Next slide. I want to make sure we stop. I'm going to go through these next couple of slides quickly so we have time for questions and comments. There's a lot of barriers to doing this, and you'll see this in your handout, but we need to overcome them. Part of that is how we communicate with the survivor, but also amongst the different team members. Next slide. And this just is another slide showing what patients want. They prefer to have shared care with their primary care provider and their oncologist, and they see different roles for the primary care than for the oncologist, whether it's for cancer follow-up, screening for new cancers, general preventative health, and comorbid management. So they sort of understand the differences, but we have to make sure they have the primary care provider to do that shared care early on. Next slide. So the bottom line is follow-up care is survivorship care, and patients have a range of physical, psychosocial, and supportive care needs that we are not adequately addressing. And we need to be able to identify them so that they can be. And we need to make sure we start their care as shared care with their primary care provider and then address the barriers as we go along. Next slide. And so I'm just going to briefly go through quickly some resources. Next slide. And some of these you may be, I just want to know if you've used NCCN guidelines at all, and if so, have you actually accessed the survivorship guidelines? Because that's a wonderful resource for you to start out with. They have general and then very specific guidelines around like cardiotoxicity, anxiety, and depression. So one of the things, besides seeing if your patients have a primary care provider, I challenge you after today, go on to NCCN. If you haven't registered, it's free. And then open up the survivorship guidelines and look at all the goodies that are in there. Next slide. So there's a variety of resources. ASCO has a lot of those things. NCI at cancer.gov has a lot of PDQ summaries about a lot of aspects of survivorship, and there's other ones as well. Next slide. And there's some for primary care as well. And so I often will include that in some of my survivorship care plans so that they know about them. Next slide. This is just a glimpse of what's there for survivorship guidelines at NCCN. There's the principles, preventative health, and late effects and long-term effects, both physical and psychosocial, especially around sexuality, sleep disorders, and things that people, lymphedema, and they're updated regularly and they're evidence-based. So please get familiar with these. Next slide. And here are a couple of others. NCCS, which is the cancer advocacy, that's National Coalition for Cancer Survivorship, have a lot of resources for patients. ASCO and their patient version is cancer.net or cancernet.org, I'm sorry. But they have a lot of good things, and so does the National Cancer Institute and Livestrong. So for patients, you'll find a lot of good resources in these sites. Next slide. So I'm just going to leave it with this last comment, which is the principles and practice priorities I just reviewed with you. Challenge the field to organize a more patient-centered survivorship care system that empowers and respects patients and provides a holistic approach to survivors' chronic and long-term needs. We do not have that. We need that. Next slide. So our job as APPs is to help them pick up their pieces and move on with their lives. And I think that we are well positioned to do that, and we should be using our follow-up visits to do that. And I think that's the last slide. Next slide, I think. Okay, so let's just stop now. I want to make sure we have a few minutes for questions and comments, and I saw that there were a few in the, there was at least one in the chat, but open up for any kinds of questions or comments.
Go ahead and advance the slide.
Great, thank you. And you can put them in the chat or you can just unmute yourself. So one of the questions that was in the chat from earlier is, what is a late recurrence? And I'm not sure that there's really a good definition, but certainly when I see patients with late recurrences, we're talking 15 and 20 years out, different cancers have different patterns of recurrence. Like if you haven't recurred in the first 5 years of your colon cancer, 98% of recurrences will occur in that first 5 years. So if you get a recurrence after that, I mean, 2% of people may recur after that, but different cancers, some cancers, it's 2 years. If you haven't recurred in the first 2 years, you're not likely to. So every cancer has its own pattern of recurrence to figure out what might be a late recurrence.
Deb, I have a question. So, talking about people's mental health and, certain groups and certain, males versus female, you'll get some people who voluntarily share that information, but many do not. In certain disease groups, that varies. One thing I will prompt people and say, so, how are you doing, emotionally about this? Or how are you doing? So what are things, questions that APPs can ask to kind of prompt and explore that, to get patients to be able to approach this more sensitive topic?
Well, we have a lot of sensitive topics. We have no problems asking people about their bowel movements. But when we ask about sex or money or how they're coping, that gets a little awkward. So I do what I consider a good one around sexuality. I do with any of these sensitive topics, which is I normalize it first. So I often will say things like, a lot of people find the second year after their diagnosis harder than the first year with managing that, because they have all these feelings come up. Are you having any issues with that? So I do that. So one is it's you're giving permission to talk about it, but you're also normalizing it so that they don't feel bad about, yeah, I'm really struggling or whatever. And I do that with a lot of these issues. The financial ones people are real taboo about too, which is, even with good insurance, most people find they're surprised about how much having cancer costs. Has that been a problem for you or your family? So I don't know if that makes sense, but it makes it a lot easier to raise it. And then they can say, no, that's fine. Then you can always say, well, if that ever becomes a problem for you or you're concerned about it, I hope you would tell me about it.
Yeah, that's great.
I know there's a lot of people online, so there's got to be other experiences that you might want to share or how you have found doing these follow-up visits work for you and your patients. We want to hear other people's stories about how this works for you or your institution. So one thing I just want to say is your institution, somebody said they don't have the ability to unmute.
So you can type your question through Poll Everywhere. You can text it. If you text UNCCN to 22333, you can do it that way, or going to POLLEV.com/UNCCN. You could type a question through there.
I know it's getting on the hour, but hopefully Katie will be able to do that. I also just want to say that as your institutions deal with the aftermath of COVID, it may be that we do different kinds of survivorship follow-up visits with telehealth, and that we're able to do different things with counseling and coaching people that way. So, hopefully you can be at the table when there's discussions about how post-COVID we want to rethink how we do these follow-up visits.
Yeah, I have found when patients finish up their treatment, they're being seen so frequently, and then we say, okay, you don't have to come back for 3 months, and we think it's a celebration, and that's a really scary time for them. So for many, I have the conversation, then I'll bring them back in 4 weeks or 6 weeks for an initial survivorship visit and starting to transition to that every 3 months. And patients are open to that. You're trying to be conscious, I think, of them having to pay for another medical visit, but I think at that point, talking with the patient, I have found there's varying responses to that.
Mm-hmm. That's a great approach. You're coming in every 2 weeks for chemo for 3 or 6 months, and then all of a sudden you're not going to see anybody for 3 months. Like, you're the safety net. The patients being seen at the same time are a safety net. And that's really an important transition. And also, that's a great time to review the survivorship care plan with them.
Yeah.
So Katie's saying something about palliative care equals survivorship care, when we really need to encourage more communication and empower PCPs to help manage late term symptoms. Well, oftentimes, like when I developed my lymphedema, I wasn't seeing anybody. I was diagnosed in Boston. I went to see my primary care provider. Most of what happens with late effects is you make a referral to somebody else, and so it doesn't matter who sees them. It's a matter that it gets picked up with those kind of things.
So a question came in, Deb. So psychosocial issues, depression, anxiety, financial toxicity, and worry over recurrence remain a self-reported major issue for survivors across the lifespan. What are ways we can assist with these issues that impact quality of life?
I think one of the biggest issues is, do we systematically assess people we see for these issues? And if we don't, we open ourselves up to disparities in the care we deliver because we're not routinely asking people the same things. And that's where patient-reported outcomes come in, which is, can we have them do a review before they come in or while they're in to identify those issues? But if we only do it for some patients and not all the patients, we're going to contribute to ongoing disparities.
Yeah. And another question, if a patient doesn't receive a survivorship plan after the last chemo treatment, what should the patient do?
Ask for one. And every time I do a cancer transitions programs, if a patient, and they may be 5 years out and they're still seeing their oncologist, I say, you let them know the next time you come in you want one. So I'm trying to stir it up from the bottom up as well as the top down. There is also a way that they can go online and create their own. University of Pennsylvania has something called OncoLife, OncoLife. And if you Google it, you'll get to their website, but they have to know what their treatments were and their diagnosis, including stage and what have you, and it will generate one for them. So they can do their own, but it's much better that they let their team know they want one. It doesn't have to be done that first visit, but it's useful then. But it can be, I give them to people who are 10 years out, and it's amazing the misconceptions you can help address when you go over what their real diagnosis was or what the drugs were that they got.
Yeah, we're at 5:01. I will comment when you speak, talking about these resources for people who use Epic, and I have created a smart phrase that has the transitions program, Live Strong, mindfulness website. So that has helped me remember to share all that each time with the patient because we get distracted and busy. So going out and finding what those resources are in your area at your institution and putting them in one either handout or your ABS, your after visit summary or something.
And then tell them it's in there so they don't just throw it away.
Yeah, valid point, yes. Thank you so much, Deb. It was a pleasure having you kicking off this program, so thank you.
I so appreciate it. Thanks for inviting me.
So thank you all for joining. And remember the website unclcn@unc.edu. Here's our phone number, call for questions. If you want to sign up for our monthly e-newsletter, please check us out online. Again, some upcoming lectures next week are one of our Research to Practice lectures, Overview of CAR T Cells and Toxicities by Dr. Grover and Faith Buchanan. On June 9th, a Patient-Centered Care on Oncologic Emergencies by Dr. Stein. And then next month, our Advanced Practice Provider lecture is on Fertility Preservation and Cancer Care by Dr. Peavy. As a reminder, all of our lectures are available online after the program. This one will be available in June to be able to view and still obtain continuing ed credit for up to a year. And our most recent lectures, Making Exercise and Wellness Part of the Cancer Experience, certainly recommend you to check that one out. Tailgating this on survivorship and how to incorporate exercise into cancer care. And then the other recent one was Immune-Related Adverse Events 2021. Thank you and have a great night.